Um, Good afternoon. Welcome to today's session and our third Arts of Birth session. These are the sessions that are being given us by SIDS Global Health in partnership with Ministry of Health. Today, we are going to discuss something related to newborn care, which is essential newborn care. With me here, I have a team of experts. I have Sister Moit. I have a guest presenter, Ms. Anderson, and I have Dr. Chris. They introduce themselves. My name is Esau Katimisa. I'm a registered nurse from Masakari Medical Hospital, and I work in the NICU. So I welcome you all, and thank you for the time that you've given us, and that we can discuss these issues that we think they are of value and they can change the way we work or improve the way we work and the care we give these newborns. So in brief, I'm going to take you through today's program. We are going to begin with introduction. These experts here are going to introduce themselves. Then we shall have a pretest, which I request you to try to answer. If the questions will be projected, will be projected on your screens, and you'll be able to see them. So your answers, we shall need you to put your answers in the chat so that you can follow up. We shall have you to tell us what you expect from the session. Then we shall get our guest presenter. We shall get our guest presenter, and after the guest presentation, we shall receive our first expert, which will be Sister Moit. She'll take her through immediate care, the newborn. And after that, she'll have Dr. Stella Choyagala, and she'll take her through the ongoing newborn care and danger signs in the newborn. So we shall have the session discussion where we shall have some questions and answers. We shall do a post test. Then we shall also get some closing remarks. So now allow me to let my experts introduce themselves, whereby I'm going to start with Mr. Mbu. Thank you, Sister Moit.
Hello, we would like to give you feedback that we didn't hear anything from Sister Moit. She was muted.
Good afternoon, Speciosa Moit. Just a comprehensive class. I work with
Thank you, Sister Moit.
Dr. Hannington, we can't hear you too. I think the other speakers are not well connected to for us to hear them well. Dear participants, please be patient and thank you for joining. The issues of volume are being sorted out very quickly. Just a few minutes, just be patient.
Please unmute. We can do away with this.
Let's try it.
I think we can hear each other right now.
Yes, we are now hearing you. That's better.
Okay, good. Let's continue with Dr. Hannington as we do it chap so that we can catch up with time. Thank you.
Yeah, good afternoon, team. I want to welcome you all for this session. My name is Dr. Hannington Kwasiwe. I'm a resident of Pediatrics and Child Health at Mara Regional Referral Hospital, Mara University of Science and Technology. You're welcome.
Thank you, Dr. Hannington. Maybe as we introduce ourselves, you can type in your expectations as we continue to introduce ourselves. So I'll ask Dr. Peace to introduce yourself.
Good afternoon. I'm Dr. Tusna Mosi, pediatrician at the Regional Referral Hospital. Very welcome to this presentation.
Thank you, Dr. Stella. Dr. Peace, Dr. Stella, you can unmute and talk to us. Also introduce yourself.
Good afternoon, everyone. I'm Dr. Stella Choyagala. I'm a pediatrician at Mbara Regional Referral Hospital. And I'm also a lecturer at Mbara University of Science and Technology, and I'm the head of the NICU at Mbara. I'm glad to be here.
Thank you, Dr. Stella. And now I'm still waiting for your expectation, what you expect learn from this session. So as you type in your expectations, you also fill in the pretest. It has been projected on your screens. You can fill in those answers in the chat section. Shall be able to get them. So please select the best option, what you feel like it is the most right answer for you, according to the question that is projected. So as we continue to do our pretest, we can have some few members, like 1 or 2, to unmute and tell us what do you expect from this session. Just raise your arm up and we shall give you the mic. Atkunda Adrin, can you hear us? Can you please unmute and maybe tell us what you expect to learn from this session. Atugonza Patrick, are you there? Maybe we can listen from us and Vakulu Mpaji.
Maybe as Hassan talks, I would like to give you a little feedback share that there are some people who have failed to see their pre-test. If the technical team can either reproject or create a link for it so that people can continue doing it.
Okay. Thank you, Dr. Stella. Still, the time is for typing in our expectations, and the chat section is open. You can type in whatever you feel like you should learn from this session. And the topic of today is elements of essential newborn care. And we can type in what you think you should learn from this session. Thank you. Okay. So we are going to have our case presenter, who is not other than Dr. Nkwasiwe Huntington, and is going to take us through the case presentation. And thereafter, we shall have some other expert presentation. So you're welcome, Dr. Huntington.
Thank you.
And the floor is yours.
Thank you. Yeah, so I introduced myself already. I'm Dr. Nkwasiwe Huntington, and we're going to be looking at a case. I hope you cannot see the screen. Are you able to see the slides? Okay.
Yes, we are seeing it.
Okay, that's good. So this was the first twin male baby of KA that was born on 13th of June at 4 p.m. and arrived at the facility on the same day at 10:40 p.m. coming from Kazo, which is about 2 hours. This 2 hours drive, 91 kilometers. The baby presented with a weak cry and difficulty in breathing that had lasted 6 hours. The mother was at home when she suddenly had a spontaneous gush of LICA and precipitated labor and immediately delivered twins with one placenta on the floor. She immediately wrapped them in a cloth and ran to the neighborhood to call her mother, who came in and tied the cords and cut using a razor blade from the shop. Both twins had a weak cry at that moment, but they later developed a difficulty in breathing. So the grandmother, mother, and the babies they rushed to a health facility in Ivanda, where the midwife whom they went to told them, just checked on the babies a little and asked them to proceed to Mbarara General Referral Hospital. She told them that their condition could not be managed at that facility. Well, we note that there was no critical or detailed examination of these babies at that facility. They were just told after a slight look that they should continue to the Regional Referral Hospital. So as they went, the second twin was noted to be bleeding from the cord and continued to deteriorate and died on the way to Mbarara Regional Referral Hospital. So the mother was a 31-year-old, para 6 plus 0. This was the 5th pregnancy, which had a set of twins. She had attended antenatal 3 times, and the booking antenatal was 2 months, or 2 months of gestation at the health center too. The 3rd antenatal was 3 days prior to delivery, and she was examined and found to have an open cervix, but there were no contractions. So the midwife advised her to go home and do a bed rest since the pregnancy was not yet at term. The mother was tested for syphilis and HIV and was found to be negative. She had no gestational hypertension or diabetes. At 3 months of gestation, she had simple malaria that was managed with artemether lumefantrine. She received IPT, TT, mebendazole, and FEFO, and there were no corticosteroids given prior to delivery. On arrival at Mbarara Regional Referral Hospital, the mother had PPH and was managed in labor ward, stabilized. Baby had not yet breastfed. So the baby whom we examined is one who was alive, and that was the first twin. The second twin had passed on the way. So when we examined the first twin, the airway was patent. The vitals that were taken immediately, the temperature was 36.1. The heart rate was 162. Respiration was 66 cycles per minute. The oxygen saturation was 88% at room air. Later, after stabilization, those are the vitals, which we may not project again, but later the baby improved when we connected CPAP. The respiratory rate was 56, saturation was 99. The birth weight, or the weight on arrival, was 1.6. And then the child generally looked pink and active, but had a weak cry, which came only after stimulation. The fontanelles were flat. There were no facial dysmorphic features. There were no limb deformities, and the spine was normal, and the anus was patent. Respiration, child was in some distress with tachypnea, nasal flaring. The xiphoid and sternal retractions were visible easily. There was reduced air entry, but no crackles in both lungs. The baby had warm peripheries. The capillary fill was 2 seconds. The pulse was of full volume and regular. Heart sounds 1 and 2 were heard, and there were no murmurs. The abdomen was soft with no defects. There were no masses, no organ enlargement. The genitalia was normal male. The cord was tied with a crocheting thread, and it was not bleeding, and it was not foul smelling. The tone was normal. There were normal reflexes, but the suckling reflex was weak. So we made a diagnosis of a very preterm first twin with respiratory distress syndrome. Our initial management, we started ordinary bubble CPAP at a PEEP of 7 centimeters of water and 100% oxygen, and maybe improved the saturation and the respiratory rate improved. We provided warmth on a radiant warmer. We gave prophylactic antibiotics, ampicillin and gentamicin. We cleaned the cord with chlorhexidine, retied it, and cut it. Baby received intramuscular vitamin K, 1 milligram, tetracycline eye ointment, and trophic feeding was initiated by spoon. We also provided IV fluids, D10, at 16 mils per kg for the first 24 hours using an infusion pump. And we prevented apnea of prematurity by giving caffeine at 20 milligrams per kg, loading dose. And then we continued monitoring the vitals. Baby was transferred to NICU when they had stabilized, and we planned a linkage for vaccination services. Thank you very much.
Thank you, Dr. Huntington, for the case presentation. And now the floor is back to us. And maybe we shall need to hear from you what you think was done well, and maybe what you think was missed. You can continue in the chat section. 1 or 2 or 3 members can raise up and discuss with us what you think was missed. I have a question in the chat section, and Ondikira is asking, why did you use CPAP to deliver oxygen?
Okay, then I respond. Okay, we use CPAP to deliver oxygen. I think that's a whole other topic together, but when you see my examination findings, you see that I was trying to do an Silverman-Anderson scoring, and this required my findings. The best way to respond to this desaturation was using CPAP according to that score. Yeah.
Okay, thank you, Dr. Huntington. You can continue sending in your questions regarding the case presentation as we continue to our next presenter. Please note other than Sister Moit. You're welcome.
Thank you very much, our moderator. I'm Moit Speciosa once again, and I'm going to take you through the immediate care of this baby. When we receive such babies, or we are alerted that we are getting a baby being referred into the facility, there's a lot that we have to do. And to go to this, first of all, have to give a brief introduction of my presentation. You find that every newborn is entitled to immediate high quality care in order to achieve quality life. And in Uganda, newborn care has shown significant progress, but challenges still persist. And as a country, we record 22 deaths per every 1,000 live births of neonates. And this is exceeding the recommended Sustainable Development Goal target of 12 deaths per 1,000 live births, which is to be met by 2030. What does this imply? This implies that we still have a lot to do to see that we achieve this. And this is, we thank SEED Global for preparing such sessions. We are going to sensitize and mentor health workers to see that we achieve what is required of us. Okay. And in our care of this baby, the immediate care of our baby, after receiving a message that we are getting this baby, you find that you need to make preparations for the reception of this baby, among which we have to prepare human resource, which is going to receive this baby. And this, we are saying that we need a team of health workers, which involves at least more than one person receiving this baby, because as well, we know very well that these babies can change any time, where you may require resuscitation. And in resuscitation, I don't think we can manage as you are working alone. And secondly, we need the resuscitation equipment ready when we are receiving this baby, we are going to receive the baby. This equipment, at least some of us, all of us know some of the equipment that is required. Most important, you need to prepare a place where you're going to receive this baby. Then among our resuscitation equipment, you need an arm bag, you need the masks, you need warm towels where you're going to receive this baby and maintain the baby warm. We need a stethoscope where we are going to auscultate to see how the baby's heart is doing, how the chest is. Then we need an emergency tray with emergency drugs and fluids and other things that are required. You need oxygen, prepare oxygen and its accessories before you receive this baby. We don't want to start running up and down when a baby comes, and like we had, our baby came with distress and required oxygen immediately. Observation tray is another thing where we are going to check the baby's temperature, we check the baby's respiratory rate, we check the baby's heart rate, and the SpO2. And the bed where we are going to receive this baby, our baby being a preterm, very preterm, weighing 1.60 kilograms, I chose an incubator for this baby. And this incubator is going to be pre-warmed because remember, our baby is traveling a long distance of 90 kilometers. 2 hours on the road is quite long for this baby. And the way the baby was sent, I don't think this baby even came by ambulance. So we fear this baby may even reach us hypothermic. You saw the temperature. Our baby had 36.1. That is already an indicator that this baby required support to maintain its warmth. Then as a health worker, you need to prepare also the safety for yourself and for the baby. And in this, most important, you need the gloves, you need the sharps containers where you're going to discard what you're using. You need the bins close to you. You don't have to run here and there. We need cord ligatures and scissors. Yes, Dr. Huntington has told us when they received the baby, the cord was not well ligatured. So they had to religature the cord, and this is important because if we don't do this, then we are risking our baby bleeding and we may lose the baby in such a way. Then stationary, remember, when you work and you don't document, there will be no work done. Always have the stationary. After your work, you're going to document what you have done, okay? Now, the management of our baby, what are we going to do? As the nurse on duty who is receiving the baby, you're supposed to receive this baby, preferably in the BBA room. Why did we choose the BBA room? This is a baby who was born before arrival at hospital, to a health facility, born at home. Remember, they even mentioned the baby was born onto the floor. So putting this baby together with other babies that we get in the neonatal unit, we may risk transferring infections to these other babies who are already in the ward. And as you receive this baby, you're going to create rapport, involve the caretakers, welcome them, offer them a seat, and introduce yourself to them so that they gain comfort and confidence in the person who is going to take over their baby. And you're going to take a brief history very fast. At least you need to know the mother's names, how old the pregnancy was. This is going to guide our management. And as for the mother, As you address her, it is important and it is humble and encouraging if you address the mother by her name, call her Madam Agnes, instead of saying, Mama, come here. It is going to put confidence in this mother and she will work together. You remember this is a teamwork. You will work well with the mother. Then you're going to take a quick general observation of the baby. As you receive the baby, please observe this baby. How is the baby's general appearance? Was the baby dried well? If the baby is not dried well, please do the needful immediately. Dry the baby, okay? Because if this baby remained with the fluid all over its body, we all know it's going to continue losing heat. And hypothermia is a very big killer in our neonates. Observe the baby's color, which should be pink. If it is not pink, say it is turning blue, then this is an emergency where the baby requires to be supported with oxygen. Then the baby's tone. Is the baby active, floppy? If the baby is floppy, you're going to take immediate action. And is the baby breathing? If the breathing is there, is it spontaneous or not spontaneous? Then you act accordingly, as we shall see ahead in our management. We are going to take vitals for this baby. We know we have seen the baby arrive to the facility with a temperature of 36.1. That was already going down for our baby. We are going into hypothermia, a pulse rate of 160. That is relatively good. Respiratory rate, which was 66 breaths per minute. This was already a sign of respiratory distress, and this baby needed support. And the SpO2 of 88% at room air. This is an indicator of respiratory distress, so we needed to. And when you find this in this baby, you don't have to continue with other things. You're going to immediately support this baby's breathing with oxygen. Then after this, we are going to weigh the baby. Why are we taking the weight immediately? Yeah, we all know that in neonates, we are basing our management on the baby's weight. Whatever we are going to do, if you're giving medications, you're going to calculate your doses according to the baby's weight, even the IV fluids, the feeds, everything is based on the baby's weight. And this is also going to direct us onto where we are going to manage our baby from. Are we putting in the incubator? Are we putting in an open bed? Or are we putting in a radiant warmer? And in this case, we chose the incubator because this baby was small, below 2 kilograms body weight. Okay, now at this point, after doing all the needful, we are transferring our baby to an incubator, and this is for thermocare. Incubator, which I said we are pre-warming after receiving a message that we are getting the baby. If the message did not come to you, please, and you see them coming in, turn on the incubator as you're doing these other things of warming and the like. By the time you finish, your incubator will be ready to receive the baby. If you put this baby in a cold environment in the incubator, it may take long to gain warmth as babies respond with the environment. If you put them in a cold environment, they are going to continue going hypothermic. Here I'm noting that KMC is not ideal for now for our baby, as the baby is not yet stabilized. So we are maintaining incubator for now. Then we are connecting our baby onto oxygen, preferably a CPAP. Why are we using CPAP? Dr. Hannington tried to answer this to us. And remember also, this baby is small, it is premature, preterm. The lungs are not mature enough to maintain themselves on recoil. And so we are using a CPAP which is supporting the baby's lungs to expand and allowing air circulation. Also, this CPAP is going to support the baby continue producing the surfactant that is required for the normal functioning of the lungs. Then we are going to provide a diaper or a nappy for this baby. These days, we are using diapers everywhere, but you don't have to force the mother to bring you a diaper if she cannot afford. We know how to make nappies for this baby, improvise with a cloth, and formulate a nappy for this baby. This is going to prevent the spread of urine. For instance, if the baby passes urine and we don't have something to collect this urine together, then we shall get issues with the urine spreading all over the bed, and we shall get the baby going hypothermic. Then we shall give a head cap for this baby, also for thermoregulation. And also we prefer to nurse this baby in a nest. A nest is, most nurses here and midwives at least know how to make a nest. It is formulated in a way like a bird's nest where it hatches its eggs from, and it lays the eggs and hatches its young ones. This one will make our baby comfortable, and the baby, remember, it has gone through a rough delivery process. So this baby is like anxious also. Babies also respond to the things we do to them, even if they don't talk to us. So this is a baby we need to calm down and also reduce on the stress that the baby has been going through. Now, what about our cord care? Like Dr. Huntington told us, they had to shorten the cord. This time, as the person receiving the baby, you're going to quickly look at the cord. If this cord was cut too long, you're going to refashion. You're going to shorten the cord. First of all, you're going to clean the cord with normal saline and shorten it, preferably to 2 to 3 centimeters if required. That is if the cord was longer than that. And after this, you're going to apply double ligature. This is going to help us in the proper handling and management of this cord, and also reduce on the risk of bleeding. These days, I'm seeing midwives sending babies to the neonatal care unit with cords that are tied once. They even discharge these babies home with a cord that has a single ligature. Then we receive these babies after the ligature has slid off and the baby arrives to the neonatal unit dead. Let us get serious about this. Let us go back to the traditional way of ligaturing our cords, putting double knots, please. Now, in our management of this baby, since the baby was born at home, it is not coming from a healthy facility. They tried to reach a healthy facility, which just pushed them continue to Mbarara Regional Referral Hospital. We are going to do newborn examination on this baby before we hand the baby over to the doctor who is going to do the continual care of this baby. And what are we doing? This is going to involve a lot of things that we shall do, and this is to identify any potential health issues and ensure the newborn's well-being. And we are going to do a quick general assessment of this baby, then follow with a systemic assessment. Quick assessment, like I said, you look at the general outlook of the baby. Okay. How is the baby's tone? How is the baby's color? This is general. That is the first look on the baby. After taking this, and also quickly you can see that the baby is breathing or it is not breathing, the baby is grunting. Those ones very quickly. As you receive the baby, you'll observe this. After that, then you go to system by system. And in our systemic assessment, we are going to look at the head and the neck. And on the head, we are going to look at the fontanelles. Please examine them. Do we have them? The fontanelles scaphoid or they are bulging. Bulging fontanelles are not good for our baby. That is an indication that something is not right in this baby. It could be intracranial hemorrhage. Okay. Then a sunken one is an indicator that the baby may be dehydrated. You never know the hassles they went through as they were given birth to. Then we check for the eyes. Eyes, we are going to look at the eyes. We have bleeding in the eyes. We have like discharge on the baby's eyes. Some babies are born with infections on the eyes. And if we get these eyes with the discharge, we are going to clean and apply tetracycline eye ointment. Now, not therapeutic, but for treatment. Then you look at the ears. On the ears, we are going to look at the shape of the ears, the size, and then the position of the ears. Our ears should align with our eyes. The baby's ears should align with the baby's eyes. So if these ears are low set, then something is not right with this baby, and this is greatly going to interfere. If we don't realize this early, it may interfere with our management of the baby. Then we look at the mouth. On the mouth, we are going to see any deformities on the mouth. Could it be a cleft lip or palate? Okay, report this and see how we can manage. Then the nose also could be deformed following the cleft palate. This should be recorded and reported for further management. Now, next we are going to look at the cardiovascular system. And in this, you will require to check the baby's heart rate. The heart rate, we said it should be between 120 and 160. Above that, then we have issues, and below that, we have issues, and we have to handle immediately. Then you're going to auscultate. You, as the midwife receiving this baby, you're going to auscultate and identify any abnormal sounds like murmurs in the baby's heart. After that, we are going to look at the respiratory system. And in this, you're going to establish if the baby is breathing. If there is breathing, then you're going to go and assess for adequacy of breathing, of which we are going to look at the respiratory rate. Is there any noisy breathing? You're going to noisy breathing like wheezes, grunting, which are signs of distress in this baby. Is the baby using a lot of energy to breathe, respiratory effort? Then you auscultate for lung sound, like I said, and also observe the baby's chest shape, okay? Then look at the abdomen. On the abdomen, you're going to look at the shape. Some babies are born with distended abdomen, others are scaphoid, and also look at the umbilical cord abnormalities. On the umbilical cord, most common, we get omphalocele, and this has to be reported and managed. Some babies are born with intestines out, which is gastroschisis. This is going to be identified immediately by the person who is handling this baby at first. We shouldn't wait for a doctor to come. Then she tells you this baby has this and this. It is you to report to the doctor. Then as a team, we are going to work and see how to manage these abnormalities. Musculoskeletal system is another one that we have to look at in our examination of this baby. And here we are looking at the patterns of the spine. Some babies are born with the spinal abnormalities like bifida. And this is something we are not just going to leave and just handle the baby like any other baby. It requires specialized care. Then limb abnormalities like tallips, club feet. This one also has some baby, are born with club feet. This should be identified early so that action is taken. And what about feeding our baby? Yes, our baby is coming in with respiratory distress. The baby is of low birth weight, and baby is hypothermic when we received this baby. So in this case, the baby of KA, we are required to delay breastfeeding since we are unstable. We are delaying because this baby is already overworked. The baby is having difficulties in breathing. So if we encourage the mother to go ahead and put the baby on the breast, we may go with issues like aspiration in this baby, which is a killer in our neonates. And also putting feeds into this baby's abdomen, baby who is laboring to breathe, we are adding work onto this baby, which is going to also affect the baby's health. So in this case, we are going to consider EBM later, preferably 24 hours later, following stabilization. Then we are going, instead of giving the feeds, we are going to use enteral. We are going to give the baby IV fluids, and this we are going to give the baby D10, dextrose 10% at 60 mils per kilograms body weight per day. And also in our care, don't forget to involve the mother and caretakers, because most cases, we tend to be very busy and you are quiet working with the baby. Sometimes even we are rude because of the overwhelming work we are interfaced with in our work areas. And you don't tell the mother. Remember, this is a mother who has been pregnant and expecting her baby, and she wants to offer the best to her baby, of which the very first thing, she will want to put her baby on the breast. So it is your role as the person handling this baby immediately to explain to the mother that the baby's condition does not allow for immediate breastfeeding. Tell her why we are not doing this. We are going to worsen the baby's condition, so that you also allay this anxiety in the mother. If you don't work with the mother, it is going to be very hard for you to manage this baby. Then in our prophylactic care, we are giving, prophylactic care is quite important. Why? If we don't give prophylactic care, then there are these preventable diseases that we may get in our baby. The baby in this state is going to receive injection vitamin K, and this is 0.5 milligrams IM or IV, where you already have the cannula in situ. Preferably IV, because this baby has stayed for some time and it has really started realizing pain. If we keep giving multiple pricks to this baby, then we are stressing this baby more. You have an IV line. IV vitamin K is good enough to go with this baby. The baby would also receive the BCG, but we are not yet stable, so we can hold this since the baby can receive it later. Then we are going to apply tetracycline eye ointment on the baby's eyes to prevent bacterial infections in the baby's eyes. Saying immunization may be delayed considering the circumstances at birth. You say this baby was born at home on the floor, so we may be faced with issues of sepsis. Then we fail to, the vaccine may interfere with the symptoms that are going to present the sepsis to us. So we can delay and first destabilize this baby, then immunize later. Thank you for listening.
Thank you, Sister Moit, for the wonderful presentation. And in this, I've managed also to note something that you should not forget. At least when you're going to refer this baby, you've learned that when you send this baby, before you notify the person you're sending to, it may also interfere the care they are going to receive. So I think it would be better if you can notify the place you're referring this baby to, so that they can also prepare to receive the baby and give the necessary care. So I've also noted that in this, you should also need to choose the best referral option. If you refer such a baby with severe respiratory distress in a private vehicle with no one that is trained maybe to attend to this baby in case there is anything, then I think it will bring problems. We shall receive babies who are dead before arrival, and it will not be a good result. So we should also make sure when you're referring these babies, at least if the baby is unstable, refer with someone who can be able to rescue this baby in case there is something that happens in between there. So you should also ensure infection prevention should make sure that you guard this baby from gaining infections during the transit and during your care. So thank you once again, Sister Moit. And right now we are going to have Dr. Stella with ongoing in the newborn. You're welcome, Dr. Stella.
Thank you so much. And thank you so much, Sister Moit, for such a great presentation. As I wait for my slides to be shared, I would like to again reflect on the presentation of the two presenters. One, it is a right of the baby to be referred appropriately. And it is sad that just because someone never took a minute to just open this baby and look and see how the baby is doing before referral, nothing was recognized like bleeding and the baby didn't do well. And thank you, Sister Moit. It was a very clear presentation. So I've already been introduced. I'm Dr. Stella Choyagala. I'm a pediatrician and a lecturer at Mbarara University of Science and Technology. I work in the NICU full-time. Now, ongoing ENC care, the previous presenter, Sister Moit, has talked about what to do for a baby immediately after birth until they are stable. Now I'm taking on from there to the entire 1 month of life. What should we do? So ongoing essential newborn care is includes consistent attention to newborn needs from birth onwards, and we want to push them all the way to happy years in childhood. And high quality universal newborn care is the right of every newborn. So much as we say that this is essential newborn care, most people mistake it and assume that this is simple newborn care. Essential newborn care is actually the art of the standard of care for every baby, and it gives them the best quality of life if it's done well for them in these beginning days. So it's not just something simple, but it's actually very good, well-researched, high-impact interventions that will give you the best beginnings, and it will prevent you from getting later complications that will make you run around and now thinking that you're doing expert care. If everyone did the best essential newborn care, we would have less babies to stress with. And babies have a right to be protected from injury, from infections, to breathe normally, to be warm, to be fed appropriately, and to have the right referral to the next level of care. So ongoing essential newborn care includes different packages, and some of them that we are going to look at today include assessing for and managing the 8 danger signs of a newborn, continued feeding, then continued cord care, and then prolonging skin-to-skin care. As you saw in our baby, they came in sick, but then what happens when they're a bit more stable? And then colic management. And I especially added this because when we did research, we realized that much as essential newborn care is being done fairly better in other parameters, colic leads us back in danger. And then infection prevention and control, then nurturing and responsive care, and then parent care and family-centered care. So then looking at the danger signs in a newborn, we are going to go through each of them one by one. And they include poor feeding, lethargy, seizures, babies who are having a fever that is too hot, and babies who are also cold. We shouldn't only focus on a fever. Hypothermia may even be more common in newborns and even more dangerous. And then fast breathing, chest indrawing, and jaundice. Every day, and at every postnatal review, as we look after these babies, but also as we teach mothers, every day, these babies are supposed to be checked for these 8 danger signs. And we should always emphasize this to other members and the parents themselves. The knowledge should not stay with us alone, because they will leave our facilities and go home. And these are the majority of the parents. Next. So looking at poor feeding, or sometimes the baby may not feed at all, includes babies some babies will show signs of poor feeding by sucking less. They will be on the breast for only 5 minutes. A baby is supposed to be on the breast for at least 15 minutes. If not, minimum maybe at least 10 to 20 minutes, okay? Then some of them will suck poorly, as we shall see in the video. And then there are those who don't even suck at all. However much you try, you have nurses standing by this mother's bed, holding the nipple, and the baby is just not even sucking at all, and may not even open the mouth when offered the breast. Some may not wake up at all to feed, and some may stay awake, may not stay awake to finish a feed as required. And some, as a result of poor feeding, babies will end up making little urine or no urine at all. And this will lead to poor weight gain. This is another way you can tell that a baby is not feeding well. If they start losing weight too much, in the first week, they will lose some weight, which is normal and physiological, but it will not be more than 10% of the birth weight. So when they start going above 10% for term babies and 15% for prematures of the birth weight, then they are losing too much. It means their feeding is not adequate. And they will end up with complications like of hypernatremic dehydration. They will start even convulsing because of this type of dehydration due to high sodium levels. So these babies will require support on how to feed. Some babies will need for the mother to express, and you give this milk either by cup and spoon because they are still weak as they are picking up. And others will even require NG tube and will have to be admitted if they need NG tube feeding. And sometimes you even need to supplement with fluids like dextrose to as you wait for them to gain their strength and be able to breastfeed again. So let's watch a video which is next, which is showing us what poor feeding could look like. Could we optimize on the volume of the screen, please, of the laptop? Yeah, sorry about that, but there are many videos that are coming up. So let the volume of the computer be corrected. And as she's doing that, once you realize that a baby is unable to feed, and even with supporting the mother with positioning and everything else, ensure that you have them admitted so that they are able to feed well before you release them to go home.
To wake up to feed, or he does not stay awake long enough to empty the breast. Here, we compare a healthy baby. She is the baby with poor feeding sucks less, or poorly, or not at all. He may not open his mouth when offered the breast, or he doesn't act hungry. He may not wake up to feed, or he does not stay awake long enough to empty the breast. Here, we compare a healthy baby. She is alert and suckles well at the breast.
Thank you so much. Next slide. So the other danger sign is lethargy. So sometimes we have babies who are too weak. They can hardly be woken up. And sometimes the mothers are not very sure whether the baby is just sleeping or is actually sick. But for a sleeping baby, usually when you try to stimulate them, they are able to wake up and be alert. Whereas for lethargic babies, even if you stimulate them, they will weakly wake up, look at you and close their eyes and go back to sleep. And I worry sometimes for mothers who tell you that my baby can sleep. Everyone You can go and do your work, and by the time you go back, you didn't even realize that you have a baby. A visitor will come for 6 hours and nothing. No one even knows that there is an existing baby in that house. And the parents are happy that our baby rests a lot. Sometimes that's a danger sign, and it can mean that that baby is sick and is just having low energy to be able to be awake. Next slide. We can have that video to show you clearly how the two would
Observe the
appear to
baby's
be different.
movements. A baby with lethargy will have less energy than normal and appear sluggish and drowsy. Try to wake the baby. Clap or rub a foot. Notice that the baby with lethargy doesn't wake up easily. Here, we compare a normal sleeping baby. When we try to wake him, even just by clapping, he reacts normally by fussing and crying. And then he stays awake. The baby with lethargy only moves when aroused, or he doesn't move at all. Lethargy and poor feeding often overlap.
Okay, so thank you so much for that. So when you have a lethargic baby, this baby is sick and should be taken for evaluation. You should check for their sugar and see that it is normal, and you should support them in feeding and keep them warm as you take them for care. The third danger sign is seizures, which is convulsions, and convulsions can be caused by many things, but the beginning part is how do we know that this is a seizure? So some of the convulsion signs are not as obvious as adult signs of convulsions or older children, and they are usually mild, and so it takes a keen eye for you to actually realize that this baby is convulsing. For example, they may just have a staring look. They are looking without closing their eyelids, but they are not even responding to anything going around. And then they can just have quick blinking of the eyes. Then you can have recurring frightening cries. There are babies who cry and everyone turns around. If they're in a ward, you can tell that that baby is convulsing when you're 20 meters away because of that frightening cry. And sometimes you have unusual movement of the lips and then repeated jerking of the limbs. That is the obvious one that most people are able to pick. And then sometimes they will be as if they are riding a bicycle. The hands and the legs are up as if they are riding a bicycle. Those are also called convulsions. Now, parents often miss the other unusual convulsions in babies. And we encourage that every time you go to examine this baby, take at least 10 to 15 minutes, open this baby fully and see how they are moving. That is what Sister Moit was talking about, the general state. Look at this baby. Don't just go and open and close in 1 minute. Look at this baby. Take time as you do other things. Look for these abdominal movements and see it for yourself, because the parents will miss it. And if you recognize it, teach them so that they can see if the baby has more. So there is a video.
Convulsions are the third danger sign. Features of convulsions in a newborn are often subtle, such as a staring look, blinking of eyelids, and unusual movement of the lips. Convulsions can also be more obvious. In this baby, we see tight flexing of his feet and repetitive jerking of his arm.
So thank you. So when you find the seizures, do a quick blood sugar. And if it is less than 2.6, it could be the hypoglycemia causing that. You give dextrose 2 mils per kilo. And if it is not, the sugar is normal, you can start with phenobarbital. I'm not going to go into the details, but we usually give phenobarbital as the initial drug, and it's given as a loading dose of 20 milligrams per kg. Please do not give diazepam to our newborns for managing seizures. And then the next danger sign is a baby who is too cold, which is a danger sign that is often ignored, and yet is the one which is too dangerous in newborns. Babies who are cold, they end up dying. They have the odds of dying of more than 6. Most studies have found 6 to even more than 10 times than a baby who is not having danger signs. The person sharing my slides, you've gone further ahead. Yeah, so please go backwards. So when the baby is cold, teach the mother. You go and teach, and we need to educate the parents on how to assess for hypothermia. They can usually feel for the temperature over the forehead and the feet, as well as the tummy. If the baby is cold in those areas, that baby is too cold and they will need to be warmed up immediately. And the interventions we encourage, start with skin to skin as you're setting up your warmer and everything. For babies whose temperature is above 35.5, you don't need a warmer. Skin to skin care, if the baby is not unstable, is okay. But in case they are less than 35.5 first, and you have a warmer available, start with the warmer, and then you can continue with skin to skin. But either way, if you have no warmer, any temperature, even if it's 33, do kangaroo mother care or kangaroo parent care, and they will actually correct their temperature. What I would want to note is that hypothermic babies, usually the coldness is associated with hypoglycemia as well. And also it is associated with serious infections. And if you try warming this baby with skin to skin and they are not responding, that is a sign of infection. You need to treat this baby for sepsis and look for other signs of sepsis in the baby. Next slide. There is also a video to show us how to look for hypothermia.
Temperature is the 4th danger sign. Compare the baby.
And then the next is a baby who is too hot. And usually baby's body will feel hot to touch compared to your own body. And the mother may report that the baby's mouth is hot when they try to breastfeed. That's how sometimes the mother will tell you that the baby is hot. And one-time temperature of 37.5 to 38.5 can also be due to overcovering. And sometimes immunization, because in our immunization schedule, we've introduced hepatitis B at birth. It causes a bit of temperature in some babies on day 1. So you need to be sure that it's not overcovering. And when the fevers are persistent after, so what we do for these babies, we first, once you get a fever, first expose for at least 10 to 30 minutes. And after that, you retake the temperature. And if they are still hot, or in case you've gotten this fever on more than one occasion, then that is a true sign of infection or other pathological causes of fever. So you need to treat that baby or send them for treatment for possible infection. And then if a baby is otherwise well, you just expose, like I said, and if the temperature goes down, you don't have to treat for sepsis. You can keep around for another 24 hours to see if they will remain normal, since the temperature went down after exposure. Don't discharge immediately such a baby, just keep around for observation. You don't have to give antibiotics. And then next slide. The other danger sign, okay, we have a video for that. Yeah.
Sign. The baby's body will feel hot to touch compared to your own body. The mother may report that the baby's mouth is hot on her breast. The face and body may look flushed. A temperature more than 37.5 degrees is too high. Cool the baby off by removing his clothes for 10 minutes. If the baby is still too hot or looks unwell, this is a danger sign.
Okay. Okay, so some mothers actually tend to feel bad when you expose the babies. Explain to them that it is okay and it's not going to harm the baby, because they always feel like, oh, our baby is going to, die in the coldness. But once you've explained to them, they will understand. So the next danger signs about breathing, that is fast breathing and difficulty in breathing. And fast breathing, that's when a baby is having a rate of more than 60 breaths per minute. And for you to be able to say that this is fast, count the rate when the baby is calm. And for a full minute, we are always in a rush and people want to count for 15 minutes and multiply by 4 or for 30 minutes. For newborns, they have apneic episodes, which are normal, but these episodes are not regular. So you may count for 15 minutes when the baby was actually having their normal apneic episode, and you underestimate the respiratory rate of the baby. So take it for a whole minute. And babies who have fast breathing sometimes have chest indrawing, and they may have other signs of difficulty in breathing, like grunting and nasal flaring and chest indrawing. Then when we look at chest indrawing, next slide, which is the other danger sign, we'll have one video for the 2 danger signs. So when you look at chest indrawing, these babies will breathe with their chest going in and out as they are breathing, and we shall see that better. These babies will require respiratory support with oxygen, and they need to be admitted. So we can have the video to look at the breathing signs.
Fast breathing is the 7th danger sign. To determine if a baby is breathing too fast, count breaths for a full minute when the baby is quiet. More than 60 is too fast. Count again to be sure. Babies with breathing problems can have fast breathing or chest indrawing, and often both signs occur together. Here, we compare a baby with normal breathing to a baby with both fast breathing and chest indrawing. Nasal flaring and grunting, a sound heard on the out breath, can also be present in a baby with severe breathing problems.
Thank you so much. And the last danger sign is jaundice. We know that jaundice can appear normally in newborns, but before you set and say this is physiological jaundice, first fully assess this baby and look for risk factors of jaundice, like blood group or both plus and negative, but also any mother who is blood group rhesus negative. So jaundice will appear first on the face and it will spread down. And usually we use that to classify the severity of jaundice, that car picture. When it is on the face, it's grade 1. When it is up to the upper part of the chest, the umbilicus, is grade 2. When it goes up to the upper thighs, from the umbilicus to the upper thighs, that's grade 3. And when it goes to the upper arms and the legs, that is grade 4. And when it reaches the palms, that is grade 5, and the soles of the feet. So any jaundice of grade 3 and more, that baby should be fully evaluated and started on phototherapy. Whereas if jaundice also appears on day 1, or there is jaundice in any sick baby with other danger signs, or if this jaundice is going on beyond day 7 in term babies, this baby has jaundice that needs treatment, quickly take them to a place where they can be treated for jaundice. We can have other video on how to assess the jaundice.
Jaundice is the 8th danger sign. Jaundice appears first on the face and spreads to the trunk and then to the palms and soles. Here, we compare a baby's palm without jaundice to a palm with jaundice. Here is a baby's sole without jaundice compared to a sole with jaundice. Jaundice is severe if it's seen in the first 24 hours of life, if it's present in a sick baby, or is ever seen on the palms and soles.
So thank you for that. And those are all the visuals I had for us. Let's look at now what to do in labor suits or postnatal, where most of us are placed, but also in the community. Next slide. So what to do when you have a baby with any of the danger signs? One, a baby with any of the danger signs needs immediate treatment and referral if you cannot treat them from where you are. You need to resuscitate them immediately. We've been going through what to do for each danger sign. And then depending on the danger sign, pre-referral treatment may include antibiotics, oxygen, dextrose, anticonvulsants, but at least for all babies, you're sure that this is a danger sign. Antibiotics must be given, whether it is jaundice or difficult in breathing, antibiotics is already there. And then you need to write a quick, clear referral note like Sister Moit already talked about, and escort the baby. I want to emphasize that if you have a baby with a danger sign, escort this baby to where they are going to get treatment from. If you're in maternity or labor suit and the treatment is on the pediatric ward, escort that baby to the pediatric ward. Don't just say you go there, the referral is here. And if you're in another health center, we now have ambulances which are for free throughout the country. Honestly, these are known in the different LNMS groups. Call for them and you give this baby a better and decent referral. And help the caregiver put the baby skin to skin during transfer as they go. So the other part of essential newborn care that we are going to look at next is now the next slide. Is the ongoing, we finished the danger signs. What about the other components of the ongoing essential newborn care? One is continued feeding, and in this we shall look at how much is expected and what is the response of the baby to appropriate feeding. So breastfeeding directly from the breast is the best for continued feeding. We say that at birth, you must put the baby on the breast. When the baby leaves the labor suit with the mother, it doesn't mean that now you can give other things to the baby. No, we encourage breastfeeding and the baby should feed directly from the breast. In the first week, when the mother's milk production is still increasing, we prefer to do 2-hourly breastfeeding because they will have smaller volumes. But then when the mother feels that the breasts are getting more engorged and she has sufficient milk, 3-hourly feeds may also be adequate. If a baby is feeding adequately, the first urine should come within the first 48 hours. Some babies may not pass urine on day 1, but at least they shouldn't go beyond day 2 without passing urine. And after that, if they are feeding adequately, they should have more than 6 diapers, wet diapers. That is 6 rounds of doing susu, okay? And some can even have more. Then if they're also feeding well, their first stool must come in the first 24 hours. Please, if a baby has not passed stool in the first 24 hours, don't discharge them yet. Keep that baby around until they've made their first stool. If they are not passing stool, it may be that they have an imperforate anus that you've not identified, or other obstructive problems in the intestines, or they are probably not taking enough milk, so their bowel is not moving adequately. And this is mostly for the term babies. They should pass stool even preterms in the first 24 hours. Now, the number of rounds of passing stool after that can be as few as one motion every other day. That means they can pass through today, miss tomorrow, and pass through the next. Not
Dr. Stella,
diarrhea.
sorry, Dr. Stella, we are not getting you well.
Internet cut against. Hello,
Yes, we have you now.
can you hear me now?
Yeah, we have you.
Okay, internet was switching to another source, but I'm glad I'm back. So ensure that that I don't want people to be worried about babies who pass stool 7 times a day.
Sorry, Dr. Stella, you're breaking.
A day, 5 times a day, because it is normal in newborns. And the color should also be in this ring, be brown. Green stools are not bad. And then the other thing, and as babies go on, full nipples and a lot
Dr. Stella?
coming, sometimes little, people they do not get breastfeeding.
Dr. Stella?
Next slide.
Dr. Stella?
Yes, please.
I think your network
Yes, please.
Your network is breaking. I
Internet.
think you need to.
Hello.
Yeah, we can get you well now. You can continue.
Is this a better?
Still
Okay,
breaking.
thank you. Sorry about that. Our power went off, so now I'm on phone internet, but I'll try my best to wind up. Hello?
Yes, Dr. Stella, we are hearing you.
My God. Is that better? Is this a better? Can you hear me?
Yes, you can continue.
Okay, can we go to the next slide? Okay. Next slide. The other one is continued skin to skin care. And we encourage continued skin to skin care in babies who are usually small, less than 2.5 kilos, and babies who are less than 2.5 kilos, and babies who are still not so well, babies who are like having birth asphyxia and they've not yet stabilized, or sick babies who are not yet stable, and also term babies who are stable. Reason being that continued skin to skin care promotes bonding, better thermal care, faster weight gain, lower risk of infections even when you're at home, and better breathing and better neurodevelopment. So if you institute this in even term babies who are okay at home, you're reaping the benefits as well. So do not hesitate to start kangaroo care because the baby is not preterm. But also remember to involve the fathers. The fathers are very important in doing kangaroo, and other members at home when you have more than one baby. But that helps the babies to have a better brain development. Next slide. And then the other element that we would like to look at is colic. And colic is a big challenge for most parents. And this is because it is a frustrating moment. People get exhausted with colic and families break up because of colic. Now, what is colic? Colic is excessive crying in an otherwise a healthy baby or infant, and it typically lasts for more than three or more hours a day, for 3 or more days a week, and also for at least more than 3 weeks. So every time a baby has colic, know that it's not going to go away in one day. Tomorrow it will come back and the other day it will come back, but we need to be prepared for it. So the causes of colic is that, before the causes, the symptoms that the baby with colic often exhibit: loud and intense crying that is difficult to console and usually causes fussiness and gas and difficulty in sleeping. And so these babies are likely going to keep their mothers awake the whole night. And yet by the time parents get to evening time, they also exhausted. And then the colic will often go away after 3 to 4 months. And what causes colic is usually babies, the intestines are not well developed for digestion. So sometimes they are resetting. It's a physiological change and it will later settle. But also sometimes some babies swallow air while breastfeeding because they're also learning how to breastfeed. So they will swallow air and swallow it along with breast milk. And as that air is moving in the intestines, it causes a lot of gas and pain. And also sometimes these babies are going to having what we call migraines. Babies can have migraines and they're also difficult to console themselves. So that is usually what we think causes colic, and it's just a physiological change. Once they grow up, they stabilize, and this is not a disease. Next. So in the management, we encourage that you try soothing techniques. So next slide. What are some of these soothing techniques? You can hold your baby close and cuddle them, and while gently rocking them, don't shake them too hard because that can cause bleeding in the brain, which we call shaken baby syndrome. So don't shake these babies too fast and vigorously. It should be gentle, rocking and gentle. Then you can give a warm bath. It helps them to relax. You can give soothing music. Remember, we said sometimes they may have migraines. Giving loud, destructive music and a lot of noise makes them even more irritated. Give nice, quiet, smooth music. You can do even sounds that are gentle, like flowing water and the fan and things like that. Then you can swaddle. We are going to look at a picture on how to swaddle babies. It makes them feel protected and comfortable. And then you can position them to lie on their tummy, and that may give them some relief. And sometimes you guys are as far as putting them in the car and you drive. If you've noticed, most babies during journeys sleep off, and I've had a couple that decided to do a car drive and the baby kept quiet, and when they came back, the man said, I'm sleeping here until morning time, but that is what worked for the baby. And then a gentle swing. Some people have those fancy things where you can put a baby in a small swing and they will feel better. Then the other feeding option is proper feeding techniques. Ensure good attachment and burp to remove that air which makes them get pain. Then avoid overfeeding. There are parents who keep thinking that the baby is crying because they are not satisfied. So they will want to keep adding more feeds, and that is going to cause them stomach discomfort. And then change, we usually breast milk reduces on colic, on the issues of worsening colic compared to formula. So if you can keep on breastfeeding, change from formula and go back to breastfeeding, it may help sometimes. And the parents can adjust their feeds. Sometimes if a parent is taking Coca-Cola, coffee, those things can also cause irritation. Other tips, please keep calm as a parent. Encourage the parents to keep calm and take breaks, because this is exhausting. It's not going away in 3 weeks or more. So using just being calm and taking help from other people will give you relief, a better mental state to not be angry at everyone around you and the baby inclusive. And also create a calm environment with a bit of a dark room, quietness, less noise. Consult a doctor if you're not sure that the baby is fine and you think there is a problem. But I want to tell you, my dear friends, avoid medicines for colic. Both the medical and the local medicines do not work. Your Infacol, Bonisan, Grip Water, and everything else, they don't work. They have more side effects. They have alcohol. They are just going to sedate off the baby because of the alcohol in them and cause more issues. The herbal things will irritate the tummy more. So please do not give other things. Next. So as I come to, we are getting towards the end. The other thing is code care. They talked about it and where to ligature. I'm going to say a few more things. One is that always leave the cord clean and exposed. A normal baby born from hospital, you don't have to put anything on the cord. Babies born from a dirty environment, like our case presentation, you can put chlorhexidine gel, which is called Ambigel, and other formulations only once. Then for dirt and for smelling cords, you need to clean, put chlorhexidine for a week, and admit that baby for antibiotics, okay? For granulomas, those small things which come up after the cord has fallen off, they are like small meat things. Those ones, you can burn them off with caustic pencil, or you can use normal saline and apply every day to go away. And when the cord is still there, you shouldn't immerse the baby in water too many times. Do it maybe only once a day or sometimes every other day. And the other times you shower the rest of the baby. IPC, this one is always what we talk about. Next slide. Ensure clean hands before you hold the baby and breastfeed, and always wash your hands after changing diapers. And then avoid, we delay bathing because that white coating on the baby, which is called the vernix caseosa, is a very it's like precious Vaseline for that baby. So as you dry the baby thoroughly, but don't wipe off those white things, because in a few minutes it turns into oil, which has a natural antibiotic in it and keeps the baby healthy and the baby's skin glowing. So don't wipe them off or bathe them off. And then avoid giving pre-lactio feeds or things like water and other soups to babies who are breastfeeding. They increase the risk of infection. And always remember a chain of infections. Human beings, we are the reservoirs, as you can see in that purple picture. And we spread these infections by coughing, by shaking hands, the ears, the nose, the mouth, to a very vulnerable newborn whose immunity is weak, and then they keep getting sick. So make sure you break this chain of infection as you look after newborns. Avoid handling, wear your masks when you're going to see these babies in the NICUs. And next slide. Now, I would like to take a few minutes on this slide, the next one, which is the nurturing environment. This is a new concept to some of us. We never think about a nurturing or responsive environment or doing developmental care. So what is this? This is when we offer, someone said, I want to learn how to take care of a baby with less stress. This is what we meant for you. So you need to we need to give the baby the best environment. This is like about what babies love, okay, from all of us, whether at home or in hospital. So first of all, for you to be able to do the best care for this baby for what they love, you need to involve the parents and families. You can't do it as a health worker alone. You can't look after these prematures in the NICU without involving the parents. You can't look after a newborn at home. You will not go with this mother at home. So you need to teach them. 2, you need to ensure appropriate positioning and handling of babies, and we are going to show you how. But one of the ways is avoid over-touching the baby. Swaddle the baby. You see in that first picture up, which has swaddling. That's what we mean by swaddling. Wrap this baby well. Once they are close together, they feel like they are back to that environment in the womb. and they are also feeling like you're touching them constantly and you're putting them close to you so they don't feel abandoned and lonely. Then safeguarding sleep. Babies love their sleep. So when it's time to sleep, avoid interrupting their sleep with taking vitals, with doing this. And if you're going to do so, be gentle to them. So avoid doing these procedures repeatedly. And this is when we say that you should do bundled care. Go to one baby, do the vitals, give treatment, take the weight, and finish. Don't say, let's first take the weight. You go around, take weight. Then you come back. Let's take the temperature. You take temperature. Then you come back. Time for treatment. That irritates babies so much and they don't like it. They need to have their quiet sleeping time. Then minimize pain and stress. Babies feel more pain than adults than you. So all this cannulation we do, sometimes you're cannulating up to 20 times because you fail to get a line, is not good for babies. That pain interferes with their brain development and interferes with their IQ later in life. So minimize pain. The ways you can reduce pain newborn. Let them breast procedure, and I assure you they are not going to cry when you straddle them during procedures. Then protect skin, like we said, don't bathe them too early. Optimize nutrition, we've already talked about that. Now the inner circle, the dark green circle, talks about how to respond to their senses. And this is what babies want. A healing environment should be calm. Don't have too much noise in NICUs and don't make too much noise in the baby's room at home. They love a quiet environment. And then light, when they are in the first 4 weeks of life, we don't like exposing them to maximum light. We prefer gentle light for them because it helps their eye development. Sound, babies don't like shouting things and noise, so stop having noisy phones and ringtones when you're breastfeeding and all that, because they are not good for them. It interferes with their brain development as they are growing up. Test, the babies love the breast milk. If you give them other things like Infacol and Bonisan, you're interfering with the taste they have for breast milk, and that may make even the other things worse, especially the love for breastfeeding. And then smell, babies don't like sharp smells. Avoid sanitizing in front of the baby, putting alcohol in front of the baby, and wearing strong perfumes. They encourage parents, because they are breastfeeding, especially the mothers. And all of you who are working in NICUs, avoid strong perfumes. And touch, babies love warm and gentle touches. So as health workers, warm up your palms before you go to touch this baby. As a mother, always massage your baby because they love your touch and they don't like rough touches, okay? So this, I know I've rushed through this and it's a lot, but at some point there will be a complete presentation on developmental care. Next slide as I finish up. So the last part is infant, parent involvement and family-centered care. And this is all to say that parents can never be left out in the care of a baby and the family. It's always good to involve them. Let the mothers, giving birth causes a lot of emotions and changes in people's lives. And during their care, we should allow parents to have the autonomy, both the mother and the father, respect their dignity, however poor they are or coming from other places, and then respect their feelings and let them make choices. You may be knowledgeable, but you need to allow them to make choices as well, as long as you've explained to them. And then parents should not be abused or disrespected. A study showed that it is for this reason that parents prefer not to come to hospital. If we love them, they will never refuse to come and deliver from hospitals. And then respect privacy and confidentiality, and you should involve them in decision-making always. And once you do that, they will find looking after a baby very joyful and a worth journey for them. So thank you so much. That is all I had for you. I'm sorry that it was long, but some of these concepts I was interested in sharing them with you. Thank you.
Thank you, Dr. Stella, for a wonderful discussion, very educative. I think you've learned a lot from it. Right now, I'm going to receive some few questions from the audience. I need at least the first two people to raise their questions so that these experts can answer them. Yes, Nelson.
Yes, thank you very much. And thank you so much, the presenter, Dr. Stella Chiwagala. I think this was really quite a beautiful presentation and quite enlightening. At the early on posted on the chat, Mr. Moderator, that where possible, you allow Stella to make a few comments on the dawns, especially on the common care of newborns, because there are these practices which I think are quite dangerous to the newborns. For instance, it has been moving there. People are talking about how about diazepam in the control of convulsion. Others are talking about oral antipyretic, and I think others go as far as even giving injectable, antipyretic like diclofenac to a newborn, something like that. So I thought it would be really imperative for Stella to mention a few things that we must actually not do for a newborn, because I can see that the attendance is quite diverse. We have people of different cadres. Thank you.
Thank you, Nelson. I think your question has been noted. I think I'm not seeing any other person who would wish to answer. Maybe I will allow Dr. Stella to answer your question and we go on. Thank you.
Yeah, thank you so much, Dr. Nelson. Nice to hear from you. Concerning antipyretics, I would want to make it clear that please, we do not give paracetamol or ibuprofen or any NSAIDs or any medications for managing just a fever in a newborn without other issues. We prefer to do exposure. And most of the times, once you expose, the temperature is going to go down without need for antipyretics and analgesics. However, if a baby has a condition that is causing pain, like they've had surgery and all that, that's when we can give these analgesics to these babies. But this has to be done in a hospital setting. So please, newborns, no paracetamol for fever and no ibuprofen or diclofenac before referral to manage that fever. Concerning the developmental care, I was just giving an insight, but it is a more detailed topic on its own. And I think at some point we will have other people talk about it. And it is something we always forget about, and that has not been taught to us in schools. So I think as we get more on this information and we get more chances to present, we shall have other experts to do that, to talk about it. Thank you.
Thank you, Dr. Stella. I think we've learned a lot in this session. Right now, we are going to present our post-test. We are going to present our post-test, and feel free to fill in your answers according to whatever you've understood from the session. I think you can all be able to get the post-test. Whoever does not get the post-test, please, you can write it in the comment section. We see how we can help you. So thank you so much. Bashir, I think you can raise your question and you get answered by our experts. Tusime Bashira.
Thank you so much. And thank you so much, the presenters and Dr. Stella. My question, I was reading from the chat and I was requesting Dr. Stella to help answer the question. Someone was asking about the fluids, because the previous presenter said we give 60 mils per kg per day. So we were requesting for Dr. Stella to elaborate about the fluid management. Maybe a brief summary, because people were constantly asking about it in the group chat. Thank you.
Thank you. Thank you, Bashira. Let's also get a question from Chirabo.
Hello. Greetings, and I appreciate the team for the efforts and the services of DCPDs. I just wish to have a simple talk or mention about the possible causes of oral and cleft palates as one of the efforts to talk about the health education to the mothers. I think that's possibly what I would like to have a say about. Thank you very much.
Okay, thank you so much. We'll allow Dr. Stella to answer those two as we are receiving more.
Thank you so much. And Sister Bashira, concerning the fluids to give in a baby, that is for really babies who are above 1.5, you can start at 60 mils per kg per day of D10 if that is the first day of life, okay? Of plain D10, 60 mils per kg, and babies who are below 1.5 kilos, you can start at 80, because for them they evaporate a lot and they lose more fluid, so you can start at 80 mils per kg per day, 1 kilogram to 1.5. And then for babies who are less than 1 kilogram, we give still 80 per kg per day, but we give D5, not D10. And then I did not get the second question about the cleft palates and all that, but I thought the person was asking for time for himself to talk about it. If I got it wrong, I would request that it is rephrased. Thank you.
Thank you, Dr. Stella. You will allow me at this time invite Dr. Peace to speak to us and tell us more of the questions that have been.
Yeah, thank you so much for your audience. I've been following through the chat and I want to comment on the most asked questions. Number one is the convulsions. At the start, someone already wanted to know how we manage convulsions before even spoke about it. And it came out how some facilities are giving diazepam to these babies. So once again, our first line treatment for convulsions in these babies is phenobarbital. given IV at 20 milligrams per kg as the loading dose, and then we maintain at 5 milligrams per kg in 2 divided doses. We continue this up to 2 days after the last convulsion. So what I've usually seen in practice, people give the loading because that is the particular time when the baby is convulsing, and then they forget to maintain. We want to rest this brain as much as possible to prevent more damage by the convulsions that could be taking place even at the micro level in the brain. So that's why they need that maintenance. Other health workers have given the excuse of over sedating the baby. We're actually doing a disservice to these babies if we let them to keep hyper-stimulated by alternating from situations of being hyper alert, then sedate again when the convulsion comes. So once again, the guide is load at 20 milligrams per kg and maintain. And if we do this, these convulsions are going to be well controlled and you don't have to continue these anticonvulsants for long. But usually when we are on and off, you're going to find a baby still being managed for convulsions after a week or so. If the maximum we can load with phenobarbital is 2 times. So if we load and maintain chances are high, we are going to control the biggest percentage of these convulsions and they're not going to happen again. But should this baby who has received phenobarb loading and then as you're maintaining they convulse again, you load again with 20 milligrams per kg and then still maintain. Your goal is to give it for 2 days up to the last convulsion. So this baby should be under close monitoring. So should they have a new convulsion, this is a 3rd one after the 2nd loading of phenobarb, we then go to IV phenytoin. It's given the same dose, 20 milligrams per kg as loading dose, and we maintain at 5 milligrams per kg in 2 divided doses until 2 days after the last convulsion. And then after that, we have other options. We can go to midazolam. This is supposed to be given at a level 4 NICU where we can intubate and monitor on a vent. So in this case, if you're at a lower health center, by the time you're loading first time phenytoin and phenytoin also maximum time we can load is 2 times. You should be already thinking about referring this baby to another center. There is no room for diazepam in these neonates. This question has also come in time and again. Otherwise, you're going to suppress the respiratory center of this baby. The other question that was common also is about breastfeeding. Breast milk is the best feed for these babies. We can speak about its benefits for the whole day. So we want every baby to start with the breast milk from his or her mother. And I stress that this starts way before in antenatal to prepare the mother, to prepare the brain, because this milk comes from the brain. That milk let down process. The moment the mother locks, I am not going to breastfeed, I don't want my breast to deform. Believe me, this mother will already have little milk because the brain is already tuned not to produce milk and has already made plans to buy the milk as she might plan and what not. So in antenatal, start counseling this mother about the importance of breastfeeding and tell her she has the ability to breastfeed. So right after labor, we want to initiate the breastfeeding process within 30 minutes, if delayed maximum 1 hour. Someone asked if there is a breastfeeding option, another option for mothers who have been seizured. It is still breast milk. There's no room for giving formula because the mother has been seizured. This is the reason over time we have advocated for spinal anesthesia, because initially we were doing a lot of general anesthesia for these cesarean sections, and the mothers would take long to initiate breastfeeding, which would affect the bonding and eventually lead to the hiding of this milk. So let's use that 30 minutes to 1 hour to initiate breastfeeding. Some people will give an excuse, the milk is not there. Even the health workers themselves, the milk is not coming. Don't mind this. As long as the baby gets to the breast, that is one of the process of this milk coming. So let us support the mother. The birth process is really a stressing one. The labor and what not. That can be one of the stressors that can make this milk to hide. Like Dr. Stella has been mentioning, let us be compassionate to these mothers. This is going to help the milk to get down. Let us talk to their spouses to support them in any way possible. This is going to help the milk to come down. And then speak to the mother. Sometimes, especially first-time mothers, they are anxious about everything is happening for the first time. If they're admitted in NICU, the NICU environment is scaring, even for non-medics who are okay. So this time they are there and their little one is there separated from them. All that is the cause of a stress. Counsel them, tell them about the process in NICU, how long the baby is expected to stay, and then tell them about this milk process. The moment they are positive about it, I have counseled a mother who said, I think was a para 5 and had never breastfed and was brought by a domiciliary nurse to be prescribed the formula. But she had locked right from baby number 1 that I never have milk. But on understanding this, that her body actually has the means to produce milk, everything that happens post-labor, post-delivery is just, supportive for the milk to come. The hormones change and they are just ready there to produce the milk. So the moment you keep putting the baby, the more you put the baby to the breast, the brain is reminded that I'm now a mother and I'm supposed to breastfeed. The milk will come. And then when you breastfeed little, the brain is tuned to think, I am having excessive milk, so it is time for me to cut down. This is what we usually advise mothers, especially when their babies are admitted. Sometimes we shall limit their volume. Today we are doing 2 meals, 2 hourly, then 4 meals, and then eventually the milk comes. Once the breasts are engorged, let this milk come out of the breast. There are myths out there, different cultures. They say once this milk pours on your dress or down, it means you're burying the baby and what not. Let's take time to demystify this. The more this milk gets out of the breast, either through breastfeeding or expressing, the more the body will what? Will produce more milk. So these mothers need a lot of support during that period, right from attachment. How does the baby, attach on the nipple? How do they hold their babies to get them there? Let's support them and we shall improve this milk letdown process. So there are some desperate situations where the mother really can't have the mother's breast. The second best option would be the donor milk. But we know in Uganda, our status so far is not yet rolled out. It's currently, I think, only in Zambia and in Bali. But once it's here, let's get on board. That is the next best option for those newborn babies. And then there are situations when the mother is dead. We've tried desperate measures of sometimes getting a relative to nurse, and it really happens. But it has other implications. So when everything has failed, the third best measure would then be the formula milk. But we know it is not as good as the breast milk. And then finally, in desperate situations, the cow's milk. The dilution factor is in 1 cup, we put 0.5. In 1 cup, we put half a cup. That is the dilution factor from birth to 4 months. And after 4 months, we give the milk undiluted. But we know all this is subject to the source of the milk, whether you're really sure this milk was not diluted, and also the feeds of the animals. So many factors come in there. Once again, breastfeeding is the best for either SVD mother or scissored mother. The other contention came on constipation versus laxative use. So friends, constipation in these newborns is relative. So in the chat, we've kept saying rule out the danger signs. So when we are reviewing these babies, part of the assessment, Sister Moit stressed it, you want to know, have these babies passed stool? As you're examining the abdomen, yes, what's its volume? Is it distended? And if it's distended, how is this distension? Is it progressive? Is it associated with vomiting? How is the passage of the stool? So in every assessment, we should know, has this baby passed the meconium? And from the time of birth, we should note after how many hours did they first what? Pass the meconium. This is already helping you to relate. Like I commented, in assessment, where anytime you're assessing, keep thinking, has this child been born with a congenital anomaly? The anomalies that will make the baby known to frequently pass out stool or fail to pass out stool. And one of the clues we can have about this is when the baby has not passed meconium within the first 24 hours. So that can be one of the danger signs. And then if this distension is if this constipation is associated with vomiting and abdominal distension, that also makes you feel there's something obstructing. Otherwise, if the baby is breastfeeding well and the abdomen is soft and they are constipated, okay, they have spent days without passing urine, passing stool, we have no reason to worry. Because the abdomen is showing it is soft, meaning there is no obstruction. The baby looks healthy, is playing around and is not even vomiting. Just continue breastfeeding. The composition of this milk is eventually going to lead to that gut motility, and this baby will eventually pass stool. So in adults, we say constipation becomes worrying if there are no other associated danger signs, if it goes beyond 7 days. In babies, we are saying until day 10, as long as there is no danger sign and you are on exclusive breastfeeding. You know that the need of these babies is going to keep increasing as they what? As they grow. And besides, you know, the milk is very nutritious. So there is a time when they can be absorbing almost everything. So you don't have to worry that they will pass out hard stool. At the end of the day, when the body cannot contain it, they will pass. You should worry if the baby is on complemented feeds. You're breastfeeding, but you're also giving cow milk. Or you are giving the child formula milk. So that way, if there is constipation, you'll need to see a specialist, and we consider the enema and glycerin as we were talking about it. But in the exclusively breastfed, please don't start those things until day 10. That's in a term baby. So if there are any special features, danger signs, preterm baby, please don't give those laxatives. Let them be initiated by a specialist. Okay. I think I want to end with someone who asked about the kumida. And I keep telling mother, even to all of us, who has ever swallowed something and then you swallow and after 3, 4, 5 days, it is still lodged somewhere. So simply explaining to these mothers, it just comes to their mind. Let's do watchful monitoring for such. And if anything is worsening, you just have to rule out the danger signs. There are fevers, there are difficulty in breathing, desaturation. If it's not there, watchful monitoring. It is self-limiting. If they are not convinced or you feel there are danger signs, refer to a specialist. Thank you so much for following, and keep at it.
Thank you, Dr. Peace, for the wonderful work you are doing. And due to the time factor, you allow me invite our experts to give us some brief, small one. Yeah, some small things. Just one minute to give us something, some take home. Say that, some can take home. I'm beginning with Sister Moit. Thank you.
Yeah, thank you, our moderator. And I want to thank the team that joined us in this presentation. For me, the take-home message from this is going to request people to respond to these neonates' needs. We have learned a lot from today, and we have realized that these are a very delicate population that require critical attention and care. And once attended to, they really respond. And any delay in their management significantly contributes to their morbidity and mortality. We need to be passionate when handling them, and we also need to be timely. Thank you, Seed Global, for sponsoring this. I request us to go and put in action what we have learned today. Thank you.
Thank you, Sister Amoit. Dr. Hannington?
Yes, thank you so much all for your attendance. Just a few take-homes from me is that there's always something you can do at whatever level of the facility or the healthcare chain you are. Looking at the case we looked at, who had a chance to be helped at the first facility they went to, and because of inadequate examination at that point, the second twin died on the way to the referral site, which I think would have been prevented. So essential newborn care, being able to identify danger signs is very critical. So let's all empower ourselves, know what we can be able to do at whatever level we are before we even advance to the next level of care. Yeah, and thank you very much.
Thank you, Dr. Hannington. Dr. Stella, your closing remarks?
Thank you so much. I would like to thank everyone who has come today to listen to us, but also to Seed Global Health for sponsoring this presentation. I would love to encourage everyone to always, postnatal, let's always look out for these danger signs, because we'll save many lives before we run for emergencies. And let's also pay attention to developmental care to enable these babies have appropriate development later in life so that they can thrive. Thank you so much.
Thank you, Dr. Stella. Right now, I would request all of us, all the participants, to open your videos so that we can have a look at your faces.
So we can get to know what the correct answer as well. Who made the questions? Who made the questions?
A request, Dr. Stella, please. I have a request. Maybe you can go through the post-test questions and you give us maybe the right answers.
Okay. Let me do that as you're taking the snapshot of the participants.
So the questions are, number one, the following are danger signs.
So in that one, the wrong answer was passing 5 or more green stools. The others were correct.
In question 2, in order to ensure an appropriate nurturing environment for neonates, the following statements are true, except number 1 was the health workers should work diligently to entirely care for the baby, as parents will be exhausted after birth, minimize pain and stress, then always respond to the senses of the neonates to ensure appropriate development, Then we had also optimal nutrition is key for adequate growth and development.
Yes, the wrong answer there was the one where we said that we should do everything for the parents because they are so tired. As I said, we always need to involve them. And then the others are appropriate interventions, developmental care.
Okay, number 3. Question number 3 was colic in infants is a pain to every parent. Medical options on the market like Bonisan, Infacol, gripe water are always helpful in treatment of the colic. We had it true.
I think from our question is now false. I've
Yeah.
seen the question. Mm.
Okay.
So that is false. Those products do not help with management of colic. In fact, they contain alcohol, which sedates babies, but also causes other complications of alcohol use in babies. And they do not change. Even when we've talked to parents and they insist, they come back and say they still tried that.
Okay. So question 4 was a neonate is born from the roadside on the way to the hospital. Baby is dumb and cried immediately at birth. The attendant cut the cord and tied with a clean piece of gauze and took the baby and the mother to the hospital. Regarding cord care, what would you do for the baby at the facility?
Yeah, for this baby that is delivery in that environment, we would clean with normal saline and apply Ambigel or 4% chlorhexidine in the cord. Iodine is
Okay, I think your network is breaking, but thank you so much, Dr. Stella, for delivering to us a very important information. And we are glad to have you as part of the team. Right now, I'm still requesting for all of us to open our videos so that you can take some screenshots. And we come to the end of this session. So thank you all for attending. Thanks for giving us time and your ears. Thanks for learning and unlearning. You know, learning is a process. You need to keep updating yourselves. And you allow me also thank the Seeds Global Health and the Ministry of Health for the chance they are giving us to get such important information. They are doing a very great job. And right now, you allow me declare the session closed. Thank you so much for attending.
Just wanted to guide on how to register for your CPDs because